Hi, this is Alicia Bright again. We are going to talk about the concept of inflammation as it applies to inflammatory bowel disease. So, inflammatory bowel disease, or IBD, can be classified either as ulcerative colitis, which is inflammation and ulceration of the colon and rectum, or Crohn's disease, which is inflammation of any segment of the GI tract from mouth to anus. This is an illustration of that. You can see the image on the left is Crohn's disease, and there's patches of inflammation that can be distributed anywhere between the mouth and the anus. So there's some patches you can see in this picture in the small intestine and in different places of the large intestine, whereas on the right you see ulcerative colitis, which is pretty much limited to the distal portion of the large intestine and the anus. These are both considered autoimmune disease. This involves an immune reaction to the person's own intestinal tract. Some agent triggered it, or some combination of agents. They're not sure how that works. We're going to talk a little more about autoimmunity next week, but inflammation is triggered by autoimmunity, and IBD is one example of this. Because of the inappropriate immune response, you see widespread inflammation and tissue destruction. Signs and symptoms of this include diarrhea, weight loss, abdominal pain, fever, and fatigue. Complications that can occur include hemorrhage, strictures, perforation, possibly peritonitis, abscesses, fistulas. CDI is Clostridium difficile infection, and colonic dilation or toxic megacolon, which is a condition where the colon actually dilates and becomes full of gas and stool and doesn't function well, can't pass it out, in which case the patient may end up needing an emergency colectomy. So this image on the right describes, so hemorrhage might happen because you have an erosion of the intestinal lining into an area that hits an artery, and suddenly you're hemorrhaging, or even a large vein. You're bleeding into the intestine. But we can also get strictures, which, if you think about it, scar tissue forms when you have inflammation. The lining of the abdominal wall in that image, the intestinal wall is inflamed. As you can see, the little red stripes, little patches there. And inflammation results in scar tissue. And scar tissue tightens down. If you've ever had a scar, you know that it kind of creates a little bit of a pucker. And scar tissue inside the intestine creates a narrowing of the lumen of the intestine. In fact, if you've taken care of somebody in the hospital who has a small bowel obstruction, a lot of times small bowel obstruction is formed by strictures or scar tissue in the intestine. This also has a depiction of a fistula. A fistula is an opening between an area, two areas that shouldn't have an opening between them. So in this case, the fistula is between the inside of the intestine and the inside of the abdominal area. You've also got an abscess there. Abscess is an area where there's, it's an area of a pocket of infection. There's not functional tissue in there. If there was tissue in there, it was killed by the infection. Typically, you've got pus in there, just debris from the cellular breakdown. And this can result in peritonitis or inflammation of the peritoneum, which of course is that membranous layer on top of the abdominal contents and under the abdominal wall. So the goals of treatment for IBD, everybody is working with them. One of the goals is to rest the bowel, because that will decrease inflammation. And then we also combat infection. So inflamed bowel is prone to infection, and then infection increases inflammation. So we'll administer antibiotics, antimicrobials, in order to get the infection under control, and that will help to decrease the inflammation. People with bowel inflammation are often malnourished. You can imagine if the bowel is inflamed, it's not going to be absorbing nutrients the way it should, even if the person can tolerate food, and they might not be able to tolerate eating very much. So there are probably malnutrition issues with a patient with this disease. We want to alleviate stress because if you think about it, there's a lot of neurotransmitters in your gut. When your gut gets when you're nervous about something and your gut gets tight, yeah, if your gut is inflamed anyway and it's getting tight from nerves, that's a bigger problem even than it is for the rest of us. So, helping people to relax, alleviate stress, maybe learning abdominal breathing, these can be helpful. Of course, the goal is to relieve symptoms and improve quality of life overall. So, drugs, interprofessional care. The goals of the drugs are, of course, to induce and maintain remission. This is a chronic disease. They're going to be living with it. Aminosalicylates are a classification of medication that are often used topically to relieve inflammation, to reduce the inflammation. Don't worry about the details of the names of those drugs. Just know the classification, aminosalicylates. Antimicrobials, you should all know and love by now. Those are your good old antibiotics. And of course, corticosteroids, we discussed in detail in the last section. We talked about Cushing's. Immunosuppressants are other, corticosteroids, of course, suppress the immune system, but there are other medications as well. And some that are specific for Crohn's and ulcerative colitis. There are some biological therapies and targeted therapies that are helpful as well. So, as nurses, our goals are to decrease the number and severity of the acute exacerbations. We want normal electrolyte and fluid balance. We're going to watch that carefully. We want the patient to be comfortable, to be able to follow through with their medication regimen, to have good nutrition and improved quality of life. What are we going to do? You know, the first thing in any therapeutic relationship with a patient is to establish rapport. If they feel like they can trust you and they feel comfortable with you, they're going to be much more able to discuss their concerns with you. They'll trust what you say more. So the first step in any therapeutic relationship is to establish rapport. Discuss their self-care strategies. Will help them discuss, you know, the issues around special diet, and how they're going to take care of themselves. We want to fully explain all procedures and treatments that they have. People need to know what's going on with them, and you know, of course, the physician would get permission for any invasive procedure. They have to do a surgical consent, but there are a lot of little things that we do, enemas maybe, or medications, or whatever we do. This helps build trust. It decreases the apprehension that people naturally feel when they're sick and people are doing stuff to them. And it also increases their sense of self-control, which will help them relax. During the acute phase, when someone is very sick with it, we'll focus on, of course, keeping the patient stable. So with all that diarrhea, possibly bleeding, their hemodynamic instability is possible. So we want to make sure their blood pressure is stable, their heart rate's stable, they're not losing too much blood, they're not losing too much fluid. We'll manage pain, of course, to try and keep them comfortable. Fluid and electrolyte balance, of course, if they have a lot of diarrhea. And nutritional support, of course, very important in order to help somebody to heal up. So hygiene in this situation, having a lot of diarrhea can, not only is it difficult to stay clean if they're, you know, if they have a sudden bout of diarrhea and they can't make it to the toilet on time, you know, it's messy. Imagine that. But the other thing is that having a lot of diarrhea can actually erode the skin around the anus. So we not only want to help them stay clean, all that rubbing and cleaning can actually irritate the skin. So using like a vitamin, not a vitamin, like an A&D ointment, they call it A&D ointment. It's a kind of a light barrier that nourishes the skin and keeps the stool from irritating it as much. When you've got a lot of diarrhea, it can be very acidic and kind of eat away at the skin. So we want to protect the skin, keep it clean, but not too much scrubbing. Be very, very gentle. We want to monitor eyes and nose. So if any of you have seen those white hats, they call it a hat. That's not a hat. It's shaped like a top hat with a bite cut out of one side. These are the things that they put in the toilet in order to catch urine or stool. And so for a patient like this, you'd put one hat in the front part of the toilet. Of course, they're semicircles. The other hat goes in the back part of the toilet. We can catch the urine and monitor how much they're putting out and record that in their eyes and nose on the chart. And we can also catch the amount of stool that's coming out. This is liquid stool. It's easy to measure liquid stool. And we'll put that on their eyes and nose also. It's good to be able to track how much stool is coming out. Daily weights are important for these folks. We're monitoring their eyes and O's, so daily weights are important for fluid balance, and there's an element of nutritional monitoring that goes on there. Assess bowel sounds, but not just bowel sounds. Do a good abdominal assessment on these people. With diarrhea, you're going to expect to hear hyperactive bowel sounds. You also might notice tenderness to palpation. And the abdomen should, however, be soft, and if it's becoming firm, you might be dealing with peritonitis. That causes severe pain and also kind of a rigid abdomen. So assess the abdomen carefully. These folks might also need a consult with a dietitian. It's very helpful. Teaching that we'll do with these patients include the importance of rest and diet management. The perianal care that we just talked about, drug actions, whatever medications they're on, what side effects, when to call the doctor, stress reduction. Again, stress is only going to make tummy problems worse. So this is a group of people that needs to learn how to manage their stress well. Teach them about their disease process and when to seek medical care. They might get a dietary consultant who would help with issues of getting adequate nutrition without exacerbating symptoms. We might feed them an elemental diet, in fact. These elemental diets, this is liquid nutrition of very simple, this nutrition that's already broken down. It tastes horrible, I'm told, but it is absorbed within the first 6 feet of the small intestine, so it really rests the intestine. The rest of the gut doesn't have food going through it, so it isn't stimulated and irritated, and it allows the inflammation to calm down. Part of the dietary therapy is to correct and prevent malnutrition. And of course, fluids and electrolytes, and to prevent weight loss. These folks can get really thin. Emotional support is, of course, very important. These people have a chronic illness. It's going to be frustrating. It's going to be depressing. People are going to be anxious. Therapy might be helpful. Stress management is always helpful. And there are support groups for folks with these problems. It's a very embarrassing problem. I mean, people are having to run to the bathroom all the time. It really definitely puts a cramp in your style. Problem in your social life, too. So we want to help people to be realistic about their goals and not overload themselves, not overload their schedules, but allow enough time to rest and recuperate and manage stress. And finally, this is just a little sketch of problems that people can have. This autoimmune problem doesn't just happen in the gut. There are other issues that happen also. We've kind of focused on the belly stuff because that's what we're focused on, but it's actually the autoimmune diseases come with a whole host of other problems. So this is just a little cartoon to help you learn what those are. And I hope this was helpful. We're going to move on to the next topic now, rheumatoid arthritis.